more time about this hearing. So we'd like to open the forum to any audience members who would like to ask questions of the panelists. And we'll get a mic that we can pass around and make sure that everyone can hear.
Hi, I'm Karl. I'm a pathologist practicing at the 2 Mercy hospitals. And I was just wondering about the psychological effects on the physicians that are prescribing medication. We haven't touched on that. We have a lot of medical students here. And, when a person is murdered, if you drive a car or you help bury the person, you're an accessory to murder. And by physician-assisted suicide, you're an accessory to suicide. And I think that's going to have a psychological effect on some people more than others. So I just am asking if you know anything about that.
First of all, you use the term suicide. So you're already making a value judgment of what's going on. I have to say that I've done hundreds of ethics consultations, and very often I come away thinking, if it weren't for me, this patient would have suffered miserably because the house staff didn't understand that they would have to just keep doing things to keep the patient alive in the ICU. So I got a lot of satisfaction out of that. Now, I can't say that if I made a mistake, I would feel good. I made mistakes. That made me feel bad. But doing something like this, I have to admit, made me feel good.
And I've talked to some physicians from both Oregon and Washington who have participated in this and who are not necessarily proponents, but are willing to make it known because it's totally private, right? If the doctor does this for one of their patients, it's not made a matter of public record, or they're not picking her standing outside the office and whatnot. But they all said that it did not create significant distress. They felt weird the first time, but ultimately they felt that they were helping the person. And I think, as a doc, if you get to the point where you're going to do it, I hope that you be comfortable enough. It's a life and death decision. Hopefully you're comfortable enough with it that when all is said and done, there's not a lot of, oh, what if, or did I really do the right thing? I haven't heard of that.
I've heard from the experience that some of the providers were surprised by just the difficulty of the process, the emotional difficulty that they experienced, even those that went into it with some degree of confidence. I mean, it's never easy for anybody. I don't believe, but even those that felt more confident initially, sometimes later struggled emotionally. I don't think that's universal. Every experience is going to be different.
But palliative extubation, for example, right? That's not easy. I mean, maybe it gets easier after you've done a few dozen.
Those are very different.
Right.
Hi, I'm Chaplain Al Garrison. I was glad to hear a couple of panelists looking up the reality of chaplains. We in the script system only have about half of the one committed to palliative care, taking up the courses and all that, chaplaincy. But I'm wondering, as you consider this kind of bill, I hear you talking about how doctors explore all these avenues of the individual and their hopes and their quality of their lives and all this. But I'm also worried you don't really have time to do that and go to it, basically. So is this bill, do you think, going to encourage you to do more of that or not?
I think what's interesting in the data from Oregon is going to be unique in this situation because they had 3 years of court challenges before it actually went into effect. So there was a huge amount of time to up-train all the physicians in symptom management and in communication skills. But at the end of that, after they did their sort of first assessment, what they found was that both physicians and their patients reported more satisfaction, more knowledge, more skills in pain and communication. Patients more satisfaction with pain control and communication techniques as well. So could this potentially, zooming out that question before that we all wanted to jump in on and we got caught up, could we zoom out to the 99% of patients who aren't really going to be getting training are using this as an opportunity to leverage some training, to leverage some resources. So we've got, 10,000 more of you around, so that we can do these assessments properly and treat people suffering properly for the 99% where this law is meaningless to them.
And so that all these medical students maybe consider going into our profession. I mean, there's 100,000 doctors in California, and out of those, 900 are palliative care certified. So it's not for everyone, but those of you that are in the room, hopefully you have at least a passing interest in it, right?
One of the struggles in dealing with people with advanced or serious illness or approaching the end of life is the variety of ways in which we can suffer. And we've touched on many of those tonight. And medicine is filled with hubris. And doctors in particular fancy themselves experts at most anything. We got to medical school because we were fairly talented. We got through medical school and beyond because of that as well. If you look at how physicians go into business and often struggle, and many other directions in life, that's very common. Thinking that we can address all of these avenues of suffering as physicians is likewise ridiculous. There is no way you can properly care for a person with a complicated, serious illness alone. It's just impossible. I would encourage and invite everyone in this room to build a team around you and engage them routinely and put yourself in a position where they can challenge your thinking safely and repeatedly. We have these hierarchies that exist, and doctor, attending physician always falls at the top. As a result, people suffer needlessly.
This is going to be a yes or no question, but feel free to elaborate on your answer if you feel like. I was hoping that at least everyone could give a yes or no. Do you feel that a patient can reasonably decide that life is no longer worth living without in some way being judged or labeled as wrong or having pathological thinking?
I'll start an emphatic yes. They can and should be able to decide that this isn't what they want to do anymore. I will differentiate prematurely ending life versus letting disease run its course, though. But absolutely, people should have to keep doing this.
Are we just going down the road here? I think that people have the right to, well, certainly we all have opinions about, our existential meaning and that kind of stuff. It's worthwhile to try to work with people and help them really flesh things out and make sure that everything is duly considered. But people do have a right to end their lives. They can do it themselves without physician intervention. The Hemlock Society has been showing people how to do it that way for decades. So I don't think that we have to be part of the process, but that's my own personal opinion. I think that the patient does have the right to check out.
Yes.
Yes. And with the caveat that what I described in the patterns of being of these people in my opening statement, I don't consider pathological, I just consider who they are. And this is the way they approach the world. And the answer to your question is yes, but it's not a one-time conversation. And it's not a yes or no conversation. So it's not a, hey doc, I'm done with this, and the doc says, oh, man. On you go.
I agree. It depends, yes.
One thing that I've been surprised to find during my clinical rotations is how challenging it can be on a very practical level for people to end their lives, and how often that goes wrong, and the detriment that causes to that patient and their family as they live in a successful attempt to suicide. And granted, I hope that a physician would be able to do that more effectively than a lay person. However, I think the law, the bill as written, kind of assumes that however this is done, it's going to be done effectively and painlessly and quickly. However, it doesn't seem like there's any
meaningful relationship and some understanding, enough understanding to be able to prognosticate in this situation. I think you touched on a lot of really important things there. Right? In my clinical inpatient consultation service, we see failed attempts at suicide all the time by a gunshot and too many fentanyl patches and a number of other ways that don't work very well. There are some standards on drugs. It's usually a high dose, actually an antiemetic and a high dose barbiturate. Some of the lack of stipulation around it is because those drugs aren't very easy to come by. They're expensive, and there's a couple different options. And what data does exist, what quality it may have or not from Oregon and Washington indicates that it's relatively successful. There are very few documented instances of treatment failure.
Hi, I'm Sam Jasmine, a recently retired physician, still on the bioethics committee at Hilltop. One thing we haven't touched on here is that patients are living much longer than they ever used to, and they are having more and more health issues at the time that they die. So in some cases, it may not be just one disease that has exhausted patients, the patients of the patient. For instance, the ALS was cited, but in trying to take care of the chronic obstructive lung disease and manage the diabetes, and now there's a history of DVT, and so they're having to take medication for that and address that issue. And patients begin to realize, and this is what has been communicated to me off and on, or by many people, is that there's no time to have fun. There's so much time involved in taking care of the health issues that they have in existence. They're not living. They're alive, but they're not able to enjoy life. And I think when that happens, and then there's another one that becomes, that's when they can see there is no way out to be able to ever enjoy the things that are important to them. That's when they start thinking about maybe it's time to end suffering. I think that's another issue here too. It's called aid in dying, or physician-assisted suicide. The patients, at least the ones that I talk with, and I've talked with a lot of them over the years, their concern is to avoid suffering. And that's what we're supposed to do. We are not going to cure it. We know it. But we are required to prevent suffering.
A patient like that needs good palliative care consultation.
I was wondering, I think people make a distinction a couple of times here between physician aid in dying and physician-assisted suicide. And from my experience, people who are proponents of this law strongly prefer the terminology physician aid in dying. Suicide to me seems like a relatively value-neutral term, and I was wondering just if you could comment on why this strong preference for that terminology among people who are proponents of the law.
Sure, and I mean, really, the real proponents, it's all like death with dignity and, like butterflies and rainbows, really positive things. But I do think part of it, suicide has a negative connotation, maybe it's value neutral to certain people, but I think suicide, those of us whose lives are touched by it, it's kind of a really negative thing. So there's that, and then there's also the notion that, if you commit suicide, your life insurance, or you lose certain things, and so there's a whole legal aspect of it. So I think, physician aided dying, physician assisted dying, relatively neutral.
I used to try and lean on physician-assisted suicide as sort of, because I kind of perceive it as a relatively neutral term as well. It's also the one that's predominant in the literature, so I was sort of leaning on it in that way. But it gets a bit challenging. There's, an explicit provision in this law that says this is not suicide. It doesn't, the law literally says people who do this aren't committing suicide. Now, how a law can do that, I'm not sure. There's probably some deeper ethical, moral questions there that Larry could help me with. But, it says it's not suicide. So that's kind of what swayed me in the direction of stopping to use the PAS terminology, even though that is what's sort of predominant in the literature. But there is a marketing component to this as well.
There's a huge marketing component. You know, the Hemlock Society now calls themselves compassion and choices. And who among us can be against compassion or choices, you know? And so that there's even, like the term death with dignity, you know, I think none of us can be against the concept of having death with dignity. I mean, we're all in favor of that, but it's really used, or it's been co-opted specifically by the advocates who are using it to mean physician-assisted suicide. So it's very much spin and marketing and branding, and you all should know that the Hemlock Society raised $22 million to get this passed here in California. We think they spent about $5 million actually in judicious contributions to different people in the legislature, because this was defeated the first time around in the legislature. The white liberal coastal Democrats were all in favor of it, but the Latino Democrats were not. And so in the special legislature, mysteriously, all of a sudden, certain committees were just reshuffled. It was a special session so they could reconstitute committees. People that were opponents of this bill were conveniently not put on those committees. And there was a lot of money that was spread around to get this passed. And there are people at the national level that really want to see this happen. And, you know, many of them, I'm sure, you know, for, you know, reasons of their own conscience, I think that there's a variety of reasons for people to be in favor of this. But it's a big money thing. It's a big money thing.